And if you cool only in hospital, the chance of survival decreases by 33%. If you don't cool, your chance of survival is only 50%. So in that retrospective study, yes, it makes sense to cool already out of hospital. Now let's look, it's a retrospective study, and retrospective studies have a lot of limitations. Now let's look to the randomized clinical trials. And actually there are 3 randomized clinical trials. I want to show you one which was done in Australia, where paramedics cooled outside the hospital with cold IV, with cold infusions. And this is the outcome of the study. Cooling out of the hospital had almost the same outcome as cooling in the hospital. So there was no difference in outcome. Why is that? Animal studies show benefit. Pathophysiology says you should cool early, but the randomized clinical trial does not show a difference. So why is that? Why? And this might be an explanation, why not? If you look very careful at the temperature curves, this is the pre-hospital cooling. When the patient arrived in the hospital, temperature went up again. Actually, in the hospital, there was no difference in temperature between the patients who were cooled out of the hospital and patients who were cooled in the hospital. No difference. And the second limitation is target temperature was 33 degrees. Now, where's 33 degrees? 33 degrees here. None of the patients achieved target temperature. Temperature was a mean of 34 degrees, which means 50% of the patients were even above 34 degrees. So the conclusion of this study is not pre-hospital hypothermia does not improve outcome. The conclusion of this study is temperature control was very bad. There was no cooling out of hospital, and in the hospital target temperature was not achieved. That's the conclusion of this study. I will show you another study from America with the same concept, cooling out of the hospital by paramedics. It was a large study with more than 3,000 patients, and they looked at the outcome in patients with ventricular fibrillation or in patients without ventricular fibrillation. And this is the survival. And this study, again, shows no benefit of pre-hospital cooling, neither in ventricular fibrillation nor in patients without ventricular fibrillation. No difference in outcome. So again, clinical trial, no difference. Why? Now, if you read very carefully the study, you will realize that the patients who were cooled outside the hospital, almost 30% of these patients were not cooled in the hospital. So only out of hospital cooling, then nothing, then stop. So how can this therapy work if 30% are not cooled in the hospital? So very, very poor randomized clinical trials, which gives headache. Fortunately, there's one meta-analysis in the Cochrane library, which is kind of the highest level of evidence we know, a meta-analysis of all randomized trials with pre-hospital cooling. And the authors concluded all the studies are so poor, we cannot include any study in this meta-analysis, so we cannot say if pre-hospital cooling is good or not, because there are no studies. So based on the literature, my recommendation and most of the experts recommend, start cooling as soon as feasible. If possible, already in the out-of-hospital setting. If not, in the emergency department. Don't wait for the intensive care unit to start cooling. Now, the next question is, how long should we cool? The guidelines say 24 hours. You remember that slide already? It shows the third time. That's the complicated cascades. The damage goes over hours for days, but the guideline recommend 24 hours. So why do we stop cooling at 24 hours if the damage continues for days? So why stopping at 24 hours? If you look at animal data, there is one cooling for 24 hours compared to cooling for 48 hours. And guess what? If you cool longer, you have less cell damage. So, in animal study, again, cooling longer makes sense. And the ones of you who treat neonates, in neonates, they cool for 72 hours. It's in the guidelines. Neonates cooling 72 hours, adults 24 hours. Why? Brain is brain. Probably because until recently there was no randomized trial comparing 24 to 48 hours. But fortunately, very recently, there was one randomized clinical trial published by a Scandinavian multi-center study. They looked 24 hours cooling versus 48 hours cooling. Now, animal data show a benefit. Pathophysiology says you should cool longer. Neonates are cooled for 72 hours. So what's about this study? Do you think outcome was better or outcome was the same? And as all clinical trials, no effect. 48 hours, 69% survival, 24 hours, 64% survival. P-value 0.33. It's disappointing, right? But now I will show you a magic trick. Okay? A magic trick. I increase the number of patients to 1,500, so total of 3,000 patients. And here, the same outcome, 69% versus 64% with 1,500 patients per group. Highly significant. Great effect. Here is the one with the 175. P-value, no effect. So it's just the question of power. If you include enough patients, you are successful. So the conclusion is 48 hours of cooling is better. The study was just underpowered, not enough power that the p-value becomes significant. Now, as a third conclusion, we would recommend to cool 48 hours, maybe like the neonate 72 hours. Now comes the last step. How should we cool? And I will touch this very briefly because the next speaker will go into detail. This is the perfect cooling device. You start immediately, you cool down immediately, you keep the temperature very nicely in your target, and then you rewarm slowly. That's the ideal temperature curve. These are the cooling methods available at the time on the market. We have some surface cooling devices. This is the cheap one. Ice packs and a ventilator. No company behind it. Then you have Bad Medical, the Arctic Sun. You have the M-Cool Pad. You have Gamer. And you have Cincinnati Sub-Zero, the blanket roll. And endovascular cooling, actually there's only one company, it's all. The ThermoGuard it's a catheter which is put into the central venous line and with balloons, and cold water circulates through these balloons and cools the body by cooling the blood, which is floating around this cold stick in the central venous line. Now, which one is better? Here you can see a study, 2 groups of patients. One group cooled and controlled very nicely between 34 and 32 degrees, and this group with very poor temperature control. This group had very good outcome, this group had poor outcome. So temperature maintenance, well-controlled temperature maintenance is very important. This is a disaster. This is surface cooling with no feedback device. It's a disaster. Here, that's the target temperature range, and the temperature went up, down, up, down, up, down. Disaster. So you need very well maintained temperature. Now, there are some studies comparing conventional surface cooling, so that's with ice packs, no feedback, and endovascular cooling, and this is a feedback system, and there's no wonder that feedback cooling has a better temperature control than ice packs. Now, if you look at more sophisticated surface cooling devices, like the Arctic Sun, which has a feedback device, and you compare it with endovascular cooling, so there's no difference in temperature control. There are 4 studies showing consistently the same thing, no difference in control. What's about outcome? Is there a difference in outcome dependent if you call surface or endovascular? I did my little meta-analysis myself. These are the different studies. Conventional surface cooling, so ice packs. And if you take all the studies together, there seems to be a trend of better outcome with endovascular cooling. If you compare now a sophisticated surface cooling device with endovascular cooling, so these are the 4 studies, and none of the studies show the difference, and also the meta-analysis, so all studies together, there is no difference in outcome if you use surface cooling or endovascular cooling. We spoke about keeping the patients in a range. This is published this year from the States. 4 cooling devices. This is the endovascular, 3 surface cooling devices, and only the first 2 showed a good control of the temperature range, plus minus 0.5 degrees. The other 2s, they have poor temperature management. They don't, so it's better to use one of these 2. There's one caveat for endovascular cooling. Also this year, 2018, there was a study looking at thrombotic events with endovascular cooling. This is endovascular cooling. This is the number of thromboses. And 16% of the patients with endovascular cooling had a thrombus, some of them leading to pulmonary embolism, and the patients died. That's the control group with normal central venous catheters. So no patient had thrombosis. So it seems that this cooling catheter kind of has problems with thrombotic events. So having said that, that's my summary slide. 33 degrees, as soon as feasible, for 48 hours, maybe 72 like the neonates, and use a feedback system. There's no difference in outcome between surface and endovascular, but endovascular is the caveat, as shown in the last study. Maybe there seems to be some thrombotic events. So thank you very much.